Yes. Oh, thank you, Kylie. I just saw you reminded me too. All right. Welcome to Unit 17 on STI, sexually transmitted infections. And Carolyn is feeling very poorly today. So she asked me if I could just jump over her section, Unit 16. And so we will get to that. But probably not until next week. So we'll do STIs this morning, and then after lunch we'll get started with Unit 18, which is the reproductive unit. Okay, so here are our objectives. We've got 4 of them. The nurse's role in educating and prevention, the clinical manifestations, obstetrical implications, and treatment. We're going to start with a little pre-test. This is just to see what you know and how close you are to being knowledgeable about STIs. So I'm just going to do a little poll for each of these. They're all true and false. So to pass herpes, an outbreak must have occurred. True or false? And we've got several of these, so I'm going to only wait about 10 to 15 seconds per each. All right, so about 2/3 of you got it right. The correct answer is false. So people can transmit herpes even without having symptoms. And we'll talk about how we know if they've got symptoms or how common it is for herpes to be actually asymptomatic. This polling here is from a previous class, not the last class, but I think the one before, how they did on the exam on this quiz. So they don't necessarily represent the true answer, but you can kind of compare your group to a previous group. So you guys did pretty similar to that previous group. Okay, next question. All sexually transmitted infections are curable. True or false? Well, you guys are answering nice and quickly. So, and you guys got it right for the most part. So this is, there are some, the viral ones aren't really curable. We can treat them, but there's not a good cure for them. Next question. Get the poll up. You can be at risk for an STI even if you are in a monogamous relationship. True or false? All right, so that's most everybody. And you are correct. The vast majority of you got that one right. Because even if you're in a monogamous relationship, there is a chance that the partner isn't monogamous. Or, I mean, that somebody could stray or there's like be attacked or raped or something like that. So, yeah. If you have been cured of an STI with medicine, you can still get it again. True or false? All right. Again, you guys are right on target, so that was great. Yeah, in fact, you're at a little higher risk of getting it again if you've had it before. Okay. Having sex while menstruating can increase the risk of getting an STI. Okay, you guys are exactly, those who answered are exactly split down the middle, which is the closest I've ever seen a group to getting it right. This is true because the cervical os is opened, it's dilated slightly during menstruation, so that does allow for any bacteria or viruses to enter the female reproductive tract more easily. So it's more risk for the woman, but not the man. Although, I'm not positive because I guess it could go both ways. Probably, though, it's just the woman. Okay, if a married client is diagnosed with an STI, the clinic, the clinic must contact the spouse to notify them that they need to come in to be tested for that STI. True or false? Okay, you guys did really well better than average on this question also. So most of you got it right. I'll explain why this is false. Because of HIPAA. So it's not the nursing or the nurses or even the doctor's responsibility to contact the spouse. It is either the client, the patient needs to let the spouse know, or the health department. So any reportable STIs are reported to the health department, along with the person who has the STI is supposed to list anybody they've had sexual contact with in the last 2 months, and then the health department tracks them down and lets them know they've been exposed to an STI. So either the health department or the individual who has the STI. Okay, the best way to diagnose an STI is by culturing a specimen from the symptomatic area. This is you're not going to get a question like this on the test. Don't worry about that, but because this is kind of a detail that is not as significant to know, but most of you actually got this one wrong, and as most classes do. It's actually false, because there is a nucleic acid amplification test. There's a blood test that can be done that is actually more accurate. Let me just double check something here. Yeah, I need to follow up with that one. Okay, next poll question is, if a patient is diagnosed with an STI, the provider can give a prescription for both the patient and their sexual partner to be treated without the partner even needing to come in to be evaluated. Okay. This is another one that people are usually surprised to find out the answer to that is actually true. There is such thing as expedited partner therapy that is legal in most states, including Utah. How progressive of us, huh? So because STIs are such a health threat with such big major complications, which we'll get into those later, they actually have made it legal for a partner, the patient, to be prescribed not only their prescription for treatment, but also their partner's prescription for treatment that they just take home with them and give to their partner. And that is, like I said, called expedited partner therapy. And it's so that both partners can be treated at the same time. Ideally, of course, we would want to have the partner come in, but it can be assumed if the patient has it, their partner also has it. So that's why they do it. Okay. No STIs have ever been eliminated as a public health threat. True or false? Okay. You guys are neck and neck on that one. It's actually false. There is an STI that we'll learn about at the very end that has been eliminated. Just one though. Yeah. An STI can be acquired non-sexually. Oops, I need to publish this or set it up. Well, I've got the polls open. I can't see the chats. So I'm seeing that there are some messages in the chat box. So I'll look at those. If there's any questions, I'll look at them when we're done with the quiz. Okay. Very good. Most of you got that one right. There are, they can be transmitted obstetrically. So a fetus can acquire the infection, sadly, and also a baby during the birth process. And there's also one that we'll talk about that can be one STI that can be picked up without sex. Okay. Oh, that was all of the questions. I'll take a look at your comments. Right. Oh, Kimberly. Yeah, people can actually get pregnant if they've got a short cycle. They can get pregnant while they're menstruating. So that's not a guarantee, but yeah, that's a good point. Right. And Brooke, yes, it's the health department that contacts, not the health clinic. Yeah. So do they write too for the patient, or they write it for a partner? They write it for the patient and partner. I think they would write the second. Yeah, that's right. Like intercourse or other sexual activities. Oh, sorry, Kimberly, what was that comment referring to? The question, like intercourse or other sexual activities? The last poll. But, oh, okay. Yes. Yes. Yeah, and I'll explain what the non-sexual transmission is when we get to that STI. All right, so objective one, which is the nurse's role in educating the public about STIs. So first of all, the definitions. STIs are sexually transmitted infections which are transmitted from person to person primarily through sexual contact, but also obstetrically. and the one other case means of transmission we'll get to. So STIs is the more current term that we're using, sexually transmitted infections. Previously, we used the term sexually transmitted diseases. Way back in the 70s, it was venereal diseases. But the sexually transmitted diseases is actually, the CDC is still using that term. For some reason, I don't know why they didn't change to STIs like everybody else did, but I guess that means that STDs is not wrong to use that term. But in fact, STIs is a little bit more precise because technically pregnancy could fall under the STD category because there are some disease processes associated with pregnancy, like preeclampsia, that you could call an STD. It's not really classified that way, but if you think about it, it actually is a disease that's transmitted sexually. So, all right, this graph shows the history of STI since we started tracking them, and they have been increasing of late worldwide. When antibiotics came out in the mid 40s, that was a great thing for STIs, and probably at the time people were thinking, hey, we're going to get rid of these because antibiotics are like the miracle drug. And then what happened here with gonorrhea is it became resistant to antibiotics. And so it took a while to find another antibiotic that is it's susceptible to, which we'll talk about what that is when we get to gonorrhea. There's a slide that's, we'll talk about the 50% of newly diagnosed STIs are among 15 to 24-year-olds. There's a graph that represents that we'll get to. This shows the percentage of STIs, and you can see that the vast majority, almost 3/4 of STIs, both the newly diagnosed ones and the total STIs, is HPV, human papillomavirus. And then the other viral ones, where the bacterial ones take up a significantly smaller slice of the pie, but we'll get into more detail with those. So this gives you the estimated number of cases of STIs. And just to put these numbers into context, the US population is approximately 327 million. And so that makes it look like about 1/3 of the population has STIs, but it's actually, I'm thinking maybe these are the number of cases. So some of these are happening, a lot of these are happening to the same person. So it doesn't necessarily mean that 110 million people have the STIs. And a lot of this, there are 10 million in the age group of 15 to 24, and there's 44 million in that people in that age group. And I will get to the graph on that in a bit. Okay, so consequences of STI, they're physical, psychological, economic, and those are all listed here. So there is a large economic cost. Medically, it's a problem because of the developing resistance to the antibiotics. Psychological, sex is something that people are either really casual about it, or they're hoping that they're in a monogamous relationship. So if they're thinking they're in a monogamous relationship and they get an STI, then that's very disturbing. So they could be a sense of betrayal or guilt if they're the partner that acquired it outside of their monogamous relationship. Yeah. And then there's a social stigma with it. And then, of course, the physical consequences are huge as well, because there are some complications that can develop, such as pain and scarring, organ damage. Some of these there's no cure for, so they're just a lifelong acquisition. The major complications are about infertility, so they can cause infertility in both men and women. Women can get pelvic inflammatory disease, which leads to infertility and ectopic pregnancies. And then it can cause really serious harm to the baby, the fetus, the baby. So that is just heartbreaking. And also cancer. So as you know, HPV, maybe you don't know, but HPV is the causative factor for a lot of the genital cancers and throat cancers. So we'll talk more about that. And it also increases the risk for HIV. Okay, so nursing role is education is key. We want to promote prevention. So much better to prevent than to treat. Oh, right. Yeah, Kimberly, good point. So, see, we teach safer sex. We aren't using the term safe sex anymore, because the thought is that no sex is absolutely safe. So any sex has some degree of risk to it. So, and it's a good idea. We do, in the nursing profession, we do advocate for teaching safer sex practices, whether the individual is sexually active or not, because who knows if between now and their next visit, that status will change. Okay, so this chart goes over a lot of good information, so we'll just quickly look at that. So practice monogamy. Don't douche after sex, because that just washes the organism higher up the tract, the reproductive tract. Abstinence, unless of course there's a monogamous relationship. So abstaining from practices that would put you at higher risk. Clean your sex toys. Use other types of protection, such as condoms and dental dams for if you're participating in oral sex. That's why I've got a picture of the dental dams. Limit the number of sexual partners. Again, monogamy. Be careful with alcohol and drugs, because people do things under the influence of alcohol or drugs that they weren't planning on. Communication, like Kimberly said, you need to let people know, or hope that people will let you know if you, meaning people in general, as part of our instructions that we give our patients, whether if they've been exposed to STIs, know what your current status is, use condoms, use protection safely. Okay. Public awareness is to teach people to talk about STIs. So if they have any question, if they've got any concern about it, to bring it up with their healthcare provider, ask the nurse, or also especially their sexual partner, and encourage them to get tested for STI if they think they might be exposed. Give emotional support. Like I said, this is has a serious psychosocial implications, so it requires that emotional support. But we always want to be non-judgmental, and to help people identify their support systems. And as I said when we were taking that little pre-test, having had an STI actually puts a person at higher risk of acquiring another STI, including a recurrence of the same STI they were being treated for. All right, so if a patient is treated or diagnosed with STIs, they need to instruct their partner they need to be instructed to notify any partners from the last 2 months that they've been exposed and need to get treatment. However, some people would rather let the health department do it. That gives them that little degree of anonymity. So they're thinking, well, maybe they've had sex with somebody else and they won't know it's me that it's coming from. So that's why the health department can step in. And then after they're treated, this is the goal is to have a happy, healthy couple after treatment. So they also need to be taught to return if symptoms persist, and even to be returned to be rechecked. A lot of the STIs, they suggest that they be retested after three months after treatment, just to make sure that it hasn't come back. And avoid sexual activity until symptoms subside in both patient and partner. And also they should take the full regimen of the prescription. Sometimes people think that they can stop once the symptoms go away, but they need to take the full regimen. And these are just a little FYI. You do not need to memorize this list, but just so you know, these are the reportable STIs in the state of Utah: chlamydia, gonorrhea, syphilis, HPV, hepatitis, and HIV. Just so you know, we are not covering HIV in this unit. You will be covering HIV next semester in 1050. Okay, so this is where we're talking a little bit about who is at highest risk for STIs, or these people are disproportionately affected, so they have more cases than average. So young people between the ages of 15 and 24, racial and ethnic minorities, and this is considered to be due to a decreased access to care. So that is on the healthcare system. It's not on the minorities. It's on the healthcare system. And there are efforts being made to eliminate that disproportionality with the racial, the ethnic groups. So also men who have sex with men, just because it is anal sex is more likely to cause STIs. So anyone who's at high risk is advocated to be screened for STIs routinely, and that includes all sexually active women under the age of 24 and older women who have risk factors, such as multiple sexual partners, etc., and then any men who have sex with men. Okay, this is the graph I've been telling you we were going to get to, that shows the percentage, roughly the percentage of STIs. The purple represents the younger age group, 15 to 24. And you can see they have roughly half of all of the HPV infections and more than half of the chlamydia infections. So that is, and half of gonorrhea and herpes. So that is a pretty significant that so many of the younger people are at risk for and acquiring STIs. All right, these are some interesting charts. So you can see from this graph, hopefully this isn't too small for you to see, but any of the blue, this blue is the percentage of people who have syphilis. This section here, half the pie is men who have sex with men. So when I said that is a risk factor, I really meant it. That is significant. So most of the syphilis cases that we have going on in the U.S. today are in men who have sex with men, or this group is men who have sex with men and women. And then this just shows you the different ethnic groups, and you can see that the blacks have a lot higher incidence of STIs than do Caucasians, and Asians have the very smallest risk. Hispanics are, let's see, does it give that? Yeah. Hispanics are about midway between the whites and the blacks. Okay. So in just a second, I got to back up. It bugs me when we don't talk about the Native Americans and the Eskimos, because I mean they've really been suffering in the coronavirus, the Navajo especially, and also they have almost as high of an incidence as do the blacks. So, and again, it's the problem is the access to care. And hopefully, you've been kind of made more aware of that with the coronavirus reports as well. Okay, the causes of STI, which are exposure to the organisms, the sexually transmitted organisms, through unprotected sex by any route, whether it's vaginal, anal, or oral. And if people are using contraception that is a non-barrier method, then they are in increased risk for STIs just because they're not using the barrier methods, and having multiple sex partners. Contributing factors are lack of understanding of knowing how to prevent STIs. That's why we need to teach everyone, whether they're sexually active or not, just so that they are aware when they do become sexually active. Use of alcohol, of course, at appropriate ages. Like I mentioned before, alcohol or drugs, trading sex for favors, uncircumcised males, which that's a little bit of a controversy right now. That's by the book, but I know you can find research that that says no, it's not a significantly higher risk. But so I'm not going to ask you any test questions on that. But so just know that the understanding is that uncircumcised males are at a higher risk of acquiring and transmitting infection, but that is under debate still. And then having an STI. So if you already have an STI, then you're at increased risk for acquiring another one. Okay, so the safer sex options are to completely abstain from sexual activity, to be in a mutual monogamous relationship. However, we need to caution people about to beware the serial the serial monogamist, which is the person who says, I only have sex with you and no one else. This week, maybe next week, I'll be having sex with somebody else and no one else, or this month. So the serial monogamist is somebody who claims to only be having sex with one person, but there's a string of exposures. So they can claim to be monogamous when they actually have had multiple partners in relative recent history. So avoid having contact with body fluids or skin-to-skin contact. The biological differences are that men's symptoms tend to be more external, so they are more likely to manifest symptoms. And then women's symptoms are more likely to be internal, meaning they are less likely to have symptoms. And we'll see that as we talk about the individual cases. So diagnosing STIs are to do cultures from the symptomatic area, and then a wet mount where they take a sample and they look at it under the microscope. That's how we pick up the All of a sudden, the word metronide is always the treatment. Yeah. That pretty one that we saw a picture of. Can't believe it. Trichomoniasis. Gosh. Okay. The nucleic acid amplification test that finds the DNA of the pathogen. So the sample collection is from urine, cervical, urethral cultures, and so the specimens can be collected by the patient. They found they're just as accurate when they're collected by the patient as by a provider. So that makes a little easier on the patient to do their own collection. So most patients prefer that. And how the nucleic acid amplification test works is they take the sample, they find the RNA or DNA, and they amplify it. And then once it reaches a threshold point, they can detect it. And it's super, super accurate. It's very specific. It has definitely increased our ability to diagnose STIs. So that's part of the jump, the rise in cases that we're seeing is we now have a better method of detecting it. But also there does seem to be more community spread as well. Okay, here's our, you thought, this is actually the second Lord of the Rings reference I have for this class, or this unit. But we're going into dark places, so get your little light, because I'm going to be showing you ugly pictures, ugly pictures of ugly illnesses. So here we go. I have created kind of a rainbow theme for the STIs because we're covering 7 STIs and there are 7 colors in the rainbow. So why wouldn't I make it into a rainbow? And also it's so that it helps keep it, I've color coded it to keep it a little straight, if it helps keep the information straight in your heads. I'm always looking for ways to help make things easier for you to pick up and learn. So the next 3, actually the last 3 objectives for this unit, we're going to cover as we talk about each individual STI. So we're going to describe the clinical manifestations, the signs and symptoms, and the complications. Objective 3 is obstetrical transmission or implications. And objective 4 is prevention and treatment. So where I've got all of those objectives broken down very neatly is in the table. So you should all, I'm pretty sure I posted this on Canvas under the module page under Unit 17, there is an STI table. This is actually the first table I created, and students liked it so much, I just started making more and more tables just because I like having things organized. So this is your study guide basically for this this unit. Pretty much everything you need to know for this unit is summarized on this table. So there you go. Let's talk about chlamydia. The first color of the rainbow is red, so we're off and rolling. Chlamydia, the causative factor is the bacteria Chlamydia trachomatis, and this is what it looks like. And it is more often than not the cause of pelvic inflammatory disease. So if a woman comes in and is diagnosed with PID, pelvic inflammatory disease, they assume until proven as otherwise that she has chlamydia and treat her for chlamydia. Pelvic inflammatory disease causes scarring, so it can cause infertility and ectopic pregnancy because it can scar the fallopian tubes. So the OB implications are, aside from the ectopic pregnancy, the risk for ectopic pregnancy, and infertility because of the PID, the inflammation and the scarring. It can cause conjunctivitis and pneumonia in the newborn. So if the mom has it at the time the baby is delivered, as the baby passes through the birth canal, they are exposed to the chlamydia bacteria, and then that can cause them to have the conjunctivitis. Because of this, all newborns are treated with ophthalmic ointment to prevent neonatal conjunctivitis. So right after they're born, all babies get antibiotic in their eyes, and we don't ask to see if the mom has it first. We just since there's a risk and some women are asymptomatic, we're always just going to treat the infant to be on the safe side, because it's so much better to prevent than for it to be a problem. And I just have a statement about breastfeeding on all of the OB implications. So women with chlamydia, it is safe for them to breastfeed. Okay, 90% of women with chlamydia are asymptomatic. So that's terrible. And if they do have symptoms, it's going to be a mucopurulent cervical discharge. Men are much more likely to have symptoms than women are, and their symptoms would be a watery, white, cloudy discharge from the urethra, and also testicular pain and swelling from epididymitis and prostatitis. And then both sexes may have urethritis, conjunctivitis, draining sores from fistulas in the pelvic area. And we'll talk more about fistulas in the pelvic area in our reproductive unit. And then if symptoms appear, it is usually 1 to 3 weeks after exposure. So there's actually a column in, let's go back to the table, a column in incubation. That's just FYI. I'm not asking you to memorize this column. So don't worry about memorizing the incubation column. That's just for your reference. Oh, yeah. Let's go back. Warning, ugly picture coming up. There you go. Okay, so I forget to give the warnings for each one. So please just be prepared for ugly pictures. Okay, so this is what the white purulent discharge from the urethra would look like in a male. We treat chlamydia with doxycycline, which requires a 7-day regimen. So twice a day for 7 days. You don't need to memorize the dosage, but do remember the drug. And also, or azithromycin, where azithromycin knocks it out in a single dose. So that is the drug of choice that the provider would opt to go with if they are concerned that the patient would not finish, would not be good about consistently taking a 7-day regimen. So like a homeless individual. Or the thing is that azithromycin is much, much more expensive than doxycycline. So that could be a problem with access to care, where people are given the lesser expensive one and maybe not instructed to take the full regimen if they are even treated at all. So these are just things we need to think about. And then, like I said before, we rescreen after 3 months. Okay, next we're going to talk about gonorrhea. And I have this picture up here to help you to remember that chlamydia and gonorrhea go together like Tweedledee and Tweedledum. They are very similar in that they have similar symptoms and similar complications and similar treatments. So gonorrhea is caused by a diplococci, which you can see pictured here. So this is Neisseria gonorrhea. And it, like chlamydia, can also cause PID. It's not as common as chlamydia is, though, so that's why we usually assume that it's chlamydia. Symptoms, I'm just going to skip over the incubation period. So in men, 10 to 15% of men are asymptomatic, whereas 80% of women are asymptomatic. So again, men are much more likely to have symptoms. So they're the partner in most cases that needs to be the one to let their partner know that they've got an STI. And similar to the chlamydia, again, they have a yellowish penile discharge from the urethra. They can develop epididymitis and prostatitis. And women also, if they have symptoms, it's a mucopurulent discharge, just like with chlamydia. And it can also cause abnormal menses. So in both sexes, it can cause urethritis and then gonococcal infection. So gonorrhea is a more serious infection than chlamydia. Just remember that chlamydia and gonorrhea are similar, but gonorrhea is less common, which is good because it is also more potent. So it can also cause a gonococcal infection, which is a systemic infection that affects the joints and the meninges and the heart. Okay, treatment for gonorrhea, because it is, this is the one, remember, that became resistant to antibiotics. So it is actually, which we see pictured here, as it was developing its resistance to the antibiotics. And it's actually now only susceptible to third generation cephalosporin, which is ceftriaxone, which the brand name for that is Rocephin. So we give that as a single dose, which that takes care of the problem that they won't take the full regimen of the dosage, so that one dose wipes it out. But we also give it with azithromycin, because azithromycin, which is the same medication that we give for chlamydia, the other antibiotic, if you remember from chlamydia, was doxycycline. So this is a difference in treatment. So doxycycline is not a third generation cephalosporin, where we need that for gonorrhea. Sadly, it's already developing resistance to ceftriaxone. So right now in Japan, there are some strains of gonorrhea that are resistant even to ceftriaxone, which is horrible because we haven't really found another antibiotic that's going to work. Azithromycin works with ceftriaxone to augment the effectiveness of the ceftriaxone. So it would not be effective just on its own. It has to be, they have to be given together. Ceftriaxone is the key treatment, where azithromycin just augments it. Let's see. Oh, I didn't see your question until just now. Sorry, it didn't pop up. Yeah, okay. So like I said, some strains are developing resistance in Japan to ceftriaxone. So it's just a matter of time before it's going to be not even susceptible to ceftriaxone. So they're working on getting more antibiotics that will treat it. Okay, obstetrical implications are similar in that the infant during birth, they're at risk during birth, and that can cause a problem with the eyes. But just like, remember, gonorrhea is more has greater impact. It is a more serious illness. It causes a more serious eye, instead of just conjunctivitis in the infant, it actually causes ophthalmia neonatorum, which can cause blindness. And this is another reason why we routinely give infants eye ointment antibiotics at birth to prevent this, both the chlamydia conjunctivitis and the gonorrhea ophthalmia neonatorium from developing. It also can cause abscess if the fetal scalp lead is applied to the head during labor. So it's recommended to avoid using scalp leads if the woman has gonorrhea. And it can cause infections of the nose, lungs, and rectum, such as pneumonia would be in the lungs. And it is also safe for women to breastfeed if they have gonorrhea. Okay, moving on to syphilis. Syphilis is caused by, this is the only causative agent that has a different name than the disease it causes. So it's caused by Treponema pallidum, and it's a spirochete, which you can see here. Can't you just C-section to help avoid transfer? You could, but the risks outweigh the benefits since they are treated effectively by antibiotics. I guess if they had an if somebody wants to look that up, do they ever do C-sections for gonorrhea? Not that I'm aware of, but I just feel like the risks outweigh the benefits. I'm not seeing the answer to that pop up right away, so if somebody finds that, you can post it. Okay, so about syphilis, this is definitely the most complicated STI that we are going to talk about today. HIV would be more complicated, but we're not covering that one. There are 4 stages of syphilis, and this is the one that is way more common in men who have sex with men, if you remember. It's reinfection is common. I've got a double negative there, is not uncommon. So in other words, it's common since prior infection does not provide immunity. And 20% of people with syphilis also have HIV. HIV increases the risk for transmission. So this is just a little FYI. There is a famous, notorious study that was done called I'm going to take a poll, yes or no. Have you heard of this study? It's where they took a group of men, African Americans, and they, let's see, 400 of them happened to have syphilis, and then 200 of them did not have syphilis. So there were over 600 men in the study. Some people think that they intentionally infected the men with syphilis, but that is not the case. The men in the study already had, when they got started in the study, they already had syphilis. What is so horrible about this about this study is that after the study got started, so it went from 1932 to 1972. In the mid-40s, when antibiotics became available, they did not treat these men with antibiotics because they wanted to see how the disease would progress untreated. So it was just awful. And of course, because they weren't treated, that meant that there would be more transmission within their population. I'm not sure if Rachel talks about it or not in her class. I could ask her. Does anybody else know? Can anybody else confirm that? Oh, so Rachel did talk about it. Okay, then I don't need to talk about it if she did, or I can tell her. Oh, the ethical dilemma. Okay, it's a good example of an ethical dilemma. Yeah. So anyway, that was the bad thing about it. Is they just did not treat the men. And So I think pretty much everyone from that study has died, but yeah, it is messed up. I mean, it's how anybody ever thought that would be okay. It's just an example of, I don't want to get into the politics, but there definitely is some bias. It could, whether it's prejudice or bias, and then there's implicit bias where you have a bias against somebody and you're not even aware of it. If you've done that cultural clinical assignment, you'll get into that. So I won't go there. Okay, so OB implications are to be aware that syphilis is a torch infection. It's one of the infections that falls under the O category, O for other. And it is considered a torch infection because it crosses the placenta. Thus, it can cause damage to the developing fetus. So whereas chlamydia and gonorrhea, they didn't harm the fetus. The only harm was during the delivery process. Syphilis, it can seriously compromise the fetus. It can cause fetal demise, preterm birth, many birth defects. So it is teratogenic, so it can cause birth defects, congenital infection. So it's just awful. So right, Kimberly, they did not in the study. Maybe this is why I'll have to ask Rachel about what her information is. They did not give the men syphilis. They already had the syphilis. The bad thing was that they didn't treat it with the antibiotics. So all pregnant women, this is why we screen all pregnant women for syphilis in their very first obstetrical checkup, because there is an effective treatment for syphilis. So if we treat her for syphilis, then the pregnant woman, I should say, then that will protect the fetuses as well. So it's to treat both the fetus and the woman. Women with syphilis can breastfeed as long as there's not a syphilitic rash on the breast. And if there is, they should pump, and they want to breastfeed, they need to use a breast pump instead of putting the baby to the breast. Okay, so these are the 4 stages of syphilis. You'll notice that primary is 1, secondary is 2. Then there's a latent stage. Oh, Alina. Oh, yes. Yes, that's true. Good point. That's a good distinction to make, Alina. So, and then the third stage is latent, which is divided, and you don't really need to know the difference between the early and late stages, but do remember that stage 3 is latent and that stage 4 is tertiary. And when you hear tertiary, a lot of times we think of that as third, but it's actually the 4th stage, because in between the 2nd stage and the 4th stage is the latent stage. The tertiary stage is not infectious except for to the fetus if the woman is pregnant. All right, so again, here's that graph that reminds us that this is most common in men who have sex with men. Ugly pictures. Okay, so this is primary syphilis. The primary stage of syphilis, and it causes a chancre. It's similar to the word canker, but it is actually a different word. It's got its own word. It's the syphilitic chancre. And it's an ulcer, and it happens at the site of contact. So this was obviously oral contact on the tongue, the labia, and the penis. And it is the first sign of primary syphilis. It is painless. It doesn't look painless, but it actually is painless because the nerves are damaged, and it's hardened, and it can be smooth and weeping. Without treatment, it will eventually disappear, but it's still infectious even without having the chancre is an infectious time, and once the chancre goes away, it continues to be infectious. And it starts spreading systemically. So it starts out just at the site of contact, and then as the chancre goes away, it's spreading throughout the body systemically. So the second stage is, or secondary syphilis, is when you see the rash, and you also can get fever, flu-like symptoms. So think rash and flu. And the rash is characteristic on the palms of the hands and soles of the feet. So remember these pictures. It can also be on, other places of the body, but a lot of rashes we don't see on the palms of the hands and soles of the feet, but this particular rash we do. Okay, so the next stage, the third stage, is the latent period. And this is what it's called latent because there's no symptoms. It's asymptomatic. However, it is continuing to spread systemically. It can last, it's very variable, anywhere from 1 year to 30 years. A quarter of the cases relapse and go back into the secondary stage where they will see a rash again. And 15% of the cases progress to the tertiary stage. So that's why it doesn't matter how long ago a person had syphilis, they need to, it could have been 30 years ago they had symptoms, they still need to be treated with the antibiotic. That's why it was so bad that those men weren't treated. It's not like it went away because the symptoms went away. Okay, so the fourth stage is called the tertiary syphilis. And this is the most serious stage. It can cause the most serious complications, heart damage, blindness, central nervous system damage, death, and then these gumas, which are pictured here. These are tumors that can develop anywhere in the body. And as horrible as this looks, it is actually not infectious except for to the fetus if the woman is pregnant. All right, I've got a picture of a 1940s era nurse. So to remind you that the treatment is the same treatment that we've been giving since the 1940s, which was the very first antibiotic developed, penicillin G. So we give 2.4, well, you don't need to know the dosage, but a single dose is given in primary and secondary and also early latent stage. And then in the late latent or tertiary stage, then there would be 3 weekly doses of penicillin. If the person has an allergy to penicillin, then they are treated with doxycycline, which remember is the same medication we use for chlamydia. Oh, let's see, Kimberly, at what point can you? Yeah. You can attempt to treat it at any point. Actually, I think it is considered a cure because it does stop the progression of the disease. So it would be considered a cure. Most of our antibiotic STIs, we can cure. It's the viral ones that can't be cured. So if given penicillin in primary, it won't go on to secondary. Yes, right. So at whatever stage you give it, it will stop the progression. Okay, this is trichomoniasis. This is the one that we view on a wet mount, so you can actually see the protozoa swimming around under the slide, and it's caused by Trichomonas vaginalis, and it is a protozoa. And there's different pictures, and they look a little different depending on the strain. I've got a pile of wet towels here to remind as a visual cue that this is the STI that can be transmitted asexually or without sex. Because it survives outside the body for so long, so 45 minutes to 2 hours. So the question was, can it be transmitted on a toilet seat? Okay, so they actually did a study, and they put some trichomoniasis or trichomonas. Trichomoniasis is the name of the disease. The causative agent is trichomonas. So they put some trichomonas on the toilet seat, and they checked to see if it could survive there. And guess what? It can, which is not a comforting thought. But yes, it can survive on the toilet seat. And then they said, okay, the next step of the study, we're going to see if it can be deposited naturally on a toilet seat. So they had various women who had trichomoniasis sit on a toilet seat, and then they came and swabbed it to see if there were any deposits of trichomonas. And guess what? There were. Again, another kind of disturbing thought. So the next stage of the study is to have the trichomonas there on the toilet seat, and then have to see if it can be acquired from the toilet seat. So someone would need to sit on the toilet seat and see if they develop trichomoniasis. But guess what? Nobody's volunteered for that study. So we still don't know if it can be. However, what we do know is that it can be acquired from contaminated wet towels. So, however, this is what's going to be comforting, is it's to the younger population anyway, it's only a problem. It only seems to be transmitted non-sexually in postmenopausal women. So as long as their women are having their cycles, they have their pH of their vaginal flora eliminates or decreases the risk of them developing trichomoniasis. They might be exposed to the trichomonas, but they won't develop trichomoniasis asexually, keep using it asexually, non-sexually, just from having used a contaminated towel. So the moral of the story is don't pick up just any old wet towel. Make sure your towels are nice and dry and kept in a safe, clean place. And interestingly enough, trichomonas can be dormant for years, even decades, before women become symptomatic. So it does increase the risk for HIV, and screening is recommended for women with vaginitis or women who have other STIs. Okay, symptoms in men, and this is a reversal. Men almost never have symptoms, and if they do, it's just going to be urethritis, so painful urination, or prostatitis. And it does not seem to cause any complications in men. So men aren't usually treated, although there's no reason why they wouldn't. They don't need. They could be treated if they have the symptoms, of course, and if they know their partner has it, it would be a good idea to have them treated. But usually they just are. Always we want to treat both partners. Actually, that's the one exception. Usually we treat both partners, but when it's trichomoniasis, the men don't necessarily need to be treated. Okay. Symptoms in women, 30 to 70% have no symptoms, but those who do have symptoms have vulvar or vaginal itching, swelling, redness, painful intercourse and urination, foul discharge, and strawberry cervix. Or strawberry cervix. So they don't necessarily have all of these. They might have one or the other. Strawberry cervix, if you can just think of a little strawberry with its green leaves, because remember, green is the color for trichomoniasis. Also, appropriately, the discharge is a frothy green. So remember that other discharges were mucopurulent, so that was like a milky white. Discharge trichomoniasis is a frothy green. So that's a good reason why green goes along with this. I've got this color coded with green. So strawberry cervix means that the cervix is a really kind of bright red color, which is not normal. So that's why it's distinctive. Let's see, obstetrical implications is that it can cause infertility in men. Oh, why don't I have that as a complication in men? Yeah, I guess that would be a good reason to treat men. Anyway, increases the risk of preterm delivery in low birth weight babies. It is not, and it is safe to breastfeed with trichomoniasis, but women who are being medicated should not breastfeed while they are being treated, because the drug of choice is not one that is safe for breast milk. So the treatment is metronidazole, and that's Flagyl, and it is also given in a single dose. Oh, gosh, treatment of all partners is recommended. So yes, I'm sorry, I was using my foggy memory to, and I misstated. Just a second, because I could have sworn I read somewhere. Okay, so I was mistaken when I said you don't necessarily need to treat men. So risk, I know what it is. It's in there. We'll talk about it under reproductive. I was confusing it with BV, bacteria vaginalis in women. So we'll talk about that probably this afternoon. So I'm sorry for that confusion. I jumped the gun and got started on this since Carolyn was sick. I didn't get a chance to review my notes, so I was trusting my memory. And I just teaches me I really need to review my notes before I start teaching. All right. Risk for reinfection is high, so this is another one we retest in 3 months. Okay, so the next illness that we're going to talk about is herpes simplex virus. So it has the same name as the causative agent. There are 2 types of herpes. Type 1 has historically been considered the oral herpes, so the cold sores, fever, blisters. And then type 2 has historically been considered genital herpes. However, because of oral sex, there's a lot of crossover. So you can find type 1 in the genital region, and you can find type 2 in the oral region. So type 2 is a more potent strain. They are 2 separate strains. It's not just named after the area of the body. They are actually 2 separate strains of herpes. And the type 2 strain is more potent or more severe. Let's see. Herpes does increase the risk of transmitting and acquiring HIV. And all of these references to HIV are just for your interest. I'm not expecting you to memorize which ones are made worse by HIV, but you can see that the vast majority of them are make HIV more easily to acquire and also to transmit. Most cases of herpes go undiagnosed. How do we know this? Okay, this is how we know. What they do is they do these studies where they take a medical lab, and they shove it in a van, and then they drive it into the community, and they park it somewhere where there's a lot of people, like at a park or usually it's a college campus, and they will ask people to come in, and they'll invite them to be screened for medical issues. And so they just randomly choose people crossing in the area, and they invite them to be screened, and they screen them for everything. They screen them, for the blood pressure, maybe their blood glucose. They'll also check for all these different STIs. And at the same time, they're asking them questions. Do you have these symptoms? So they'll ask what their symptoms are. And then they find out, they do the lab test, and they find out what kind of diseases they have, even though they're not having any symptoms. So they take healthy people and screen them. And this is how they know that the vast majority of the people who have herpes actually do not even have symptoms. It's surprising. Let's see what the statistic is on that. I know it's only 14% of those who tested positive for herpes simplex virus type 2 had been diagnosed. So that means that about 86% of the people had not been diagnosed. So that doesn't necessarily mean that all of that 86% were asymptomatic, but probably a good portion of them were. Okay, once acquired, it's a lifelong infection. There's no cure for herpes. Outbreaks occur occasionally, throughout the rest of their lifetime. But the initial outbreak, once they're exposed, the initial outbreak will occur this again is if they have symptoms, 2 days to 2 weeks after exposure. And the symptom is a painful vesicular lesion at the point of contact. And it also can cause flu-like symptoms, just like what else caused flu-like symptoms? Anybody remember? Oh, it was, so it's actually syphilis. So syphilis, stage 2 of syphilis, but that's a good guess. Stage 2 of syphilis causes the rash and flu-like symptoms. So let's see. So, and it can settle. What it does is it settles in the ganglia of the nerves near the area where exposure happened. So, since it just lives in the body in the nerve ganglia for the rest of that person's life, and anytime they are have any sort of their immune system is compromised, then they'll have an outbreak. And the compromise of their immune system usually is due to stress or some other illness. That's why they call, like, a fever blister, type 1 that's on the mouth. They call it a fever blister or a cold sore, because when the person who has type 1 gets a cold sore or gets an illness like a cold, then their immune system is compromised, and that's when the opportunistic HSV will come out of its little nerve ganglia and cause symptoms. So like our first quiz question asked, it is contagious even when asymptomatic. Now, we talked about that the outbreak is near the point of exposure. So this is when the outbreak occurs, at first is experienced as a tingling sensation, and then it's followed by a red bump that progresses to be a blister, which is called a vesicular lesion. And these are very painful and last almost 2 weeks. And then the lesions heal without any scarring. Oh, question. Let's see. Some people can have one outbreak and never have one again. How do they know that they have the virus? Oh, yeah, that can happen. There's lucky few. They could be that they just have a stronger immune system and they keep it at bay. I guess it's possible. I don't know. It would be my guess if it's possible for it to go away, but the assumption is that it's just always living in the nerve ganglia, and I don't know that we've got a test to find out if it's actually totally gone, if they never have another outbreak again. Yeah, good point, Stephanie. Okay, so treatment for herpes is a giant condom. Just wrap yourself up in it because you want to prevent exposure. Obviously, that's just kidding, but it is a good idea to use a regular size condom or just to practice safer sex. Treatment is geared towards alleviating symptoms because we don't have a cure for it. There is a medication, acyclovir, and actually more currently, the newest medication, valcyclovir, which is wonderful in comparison to acyclovir, because look, acyclovir you have to take 5 doses a day for 5 days, whereas valcyclovir you only have to take 2 doses 12 hours apart. So 2 doses versus 25. I'm all for the valcyclovir. So let's see. We instruct patients to take the medication, start taking the medication as soon as they notice that tingling, the distinctive tingling. And that will just knock it out so that it won't erupt. Okay, there's a lot of OP implications for herpes. First, it is a torch infection. It can be transmitted, it can cross the placenta. Acyclovir and valcyclovir are both safe to use during pregnancy, so pregnant women should ideally be treated if they know they've got it. They should take the medication. Okay, the thing is, it's most at risk or essentially only crosses the placenta if it is the initial outbreak, the initial exposure to the infection. Okay, so if a woman already has a pre-existing herpes, whether it's type 2, usually it's type 2 that we're concerned about. If she has pre-existing herpes, she's not at risk for transmitting it to the fetus. She's only at risk for transmitting it to the baby during the birth process. So the time that herpes crosses the placenta is when the woman has the initial exposure during pregnancy. And I think I pointed that out when we were talking about torch infections earlier. So hopefully that sounds familiar. And we've started, let me say first, herpes during childbirth. If women have an active herpes lesion during childbirth, they need to deliver by C-section. So this is one where the benefits outweigh the cons. So we do prevent women who have active herpes lesions from delivering vaginally because that could cause neonatal transmission, which could be very serious for the newborn. So we always want to deliver women with, this is the third time I'm saying it, so you're going to see this information again. Deliver them if they have active vaginal herpes lesions, we're going to deliver them by C-section. Now, going back to this statement right here. Because of that fact, providers have started giving women the option to take acyclovir a few weeks when they get to be about 36 weeks pregnant, just to prevent an outbreak at the time of delivery. And that seems to be working really well. So that's gaining in popularity, treatment that we're seeing more and more of. So infected babies may have skin lesions, multi-organ symptoms, or CNS infection. Breastfeeding women. Women who have HSV can breastfeed as long as, like syphilis, they don't have any lesions on the breast. And again, like syphilis, they can pump their breasts, pump the breast milk, and then give that to the baby. Okay, moving on to human papillomavirus. This is the most common STI in the U.S. If you remember that chart, it takes up almost 3/4 of the pie. Oh, let's see, question. Are the lesions on the breast from type 1 or type 2? It can be either. Yeah, because of oral sex, it can be either. So we can't assume, but the treatment is the same for both. Whether it's type 1 or type 2, the treatment is the same. The severity is just worse for, the biggest difference is the severity is worse for type 2. Okay, let's see, the causative factor for human papillomavirus is human papillomavirus. It's also known as genital warts, so it causes these fleshy tumors on the area of exposure, and I've got pictures of those coming up. So the genital warts caused by human papillomavirus are called condylomata acuminata, which always makes me want to sing Akuma Matata. Anyway, let's see. Many strains cause cancer. We'll get into that diagram that illustrates that. They may be asymptomatic, but still contagious, just like herpes, and it's spread by skin-to-skin contact. Okay, there's that chart again, and these are the cancers. So it can cause genital cancers, and the symptoms of genital cancers are bleeding and pain and itching, discharge, change in bowel patterns, swollen lymph nodes, and it can also cause oropharyngeal cancer because of oral sex. And symptoms for those are persistent sore throat, difficulty swallowing, vocal changes, and lump in the mouth. Okay, so this lists specifically the different areas, the different cancers. So cervical cancer, most cervical cancers are caused by HPV. Vaginal cancer, vulvar cancer, anal cancer, rectal, and oropharyngeal, these are all in the female. And males can get penile cancer, anal cancer, rectal cancer, and also oropharyngeal cancer. So it's seen in both, it causes cancer in both males and females. And this chart, take a closer look at that. That's too small for me. Okay, so the blue line, on the bottom are the years starting from 1980 through 2015. So the blue represents cervical cancer, which took a significant drop when we figured out that when Pap tests became more effective in screening for cervical cancer. And then the green is oropharyngeal cancer, which is on the rise. And then red is anal cancer. And yeah, we'll just look at those mostly. So you can see that even though cervical cancer is on the decline, there are other cancers that are on the rise that can be prevented by HPV vaccination. So here are some examples of genital warts, and they're pretty ugly. Also uncomfortable for the people who have these, painful. There is no treatment for, no effective treatment for HPV. So what we want to do is prevent it, and we can prevent it with vaccination. The vaccination prevents, what this graph shows is the dark line are the cancer-causing HPV strains, and the lighter line are the ones that cause the genital warts. So you can see that HPV takes care of eliminating most of the different types of HPV, both the ones that cause cancer and the non-cancerous ones. Okay, so wart removal, they can remove it by freezing it, cryotherapy, or burning it, the electrocautery, or chemically destroying it. But wart removal does not cure the infection or stop infectivity, so they can still transmit it. Sometimes, a lot of times it clears on its own without treatment. But most people just want to get rid of it when they have symptoms. And new wart growth can occur after treatment. Okay, so the HPV vaccine, it protects against 9 strains of HPV, guarding against both the cancers and the genital warts. Gardasil is the name of the vaccine, and it is given in 2 doses between the ages of 9 and 26. So the closer the individual is to age 9 when they're vaccinated, the more effective it will be. It has recently been approved to be given in men and women between ages of 27 and 46. However, it's significantly less effective later on in life, and it costs $615 for the series, and it's not generally not covered by insurance yet because it's been so newly approved by the FDA. Let's see, question. Are the oh no, that was there before. I thought I saw a new question pop up. Oh wait, something did pop up. So if someone already has the warts, can they still get the vaccine? Yes, they can, and it would help because it could help. There are so many different strains of human papilloma virus, and the vaccine protects against 9 of them. So they used to do yes, it used to be a series of 3. So actually, I think they do still recommend that older individuals, people who get it at older ages. I can't remember off the top of my head what the breakdown is on the age group, but that they still get the 3 vaccines. But if you get it in the recommended window of time, they only need 2. So in their early teen, between the age 9 and their early teens, I think it's between 9 and 18, they only need 2 doses. And if you get it older, you need 3. The 2-dose regimen just came out like a year or two ago, so pretty recently. HPV is safe to breastfeed while people have HPV. Wait. Sorry, I started at with the bottom line. So it's not recommended to give the vaccine during pregnancy. It is not a torch infection. It does not cross the placenta, but it can, the baby can be exposed during the birth process and develop genital warts, and it can even get into the infant's respiratory tract. So, and it does increase the risk of the baby getting cancer, those same cancers that we just went over. Pregnancy causes the genital warts to grow more rapidly and to bleed more easily. So it doesn't mix well with pregnancy. Ideally, we don't want pregnant women to be suffering from genital warts. Okay, this is the last color of the rainbow. Hepatitis B. Hepatitis B is often, it's not always, but it's often transmitted sexually. So that's why we talk about it under STIs. It varies greatly from, the symptoms vary greatly from being totally asymptomatic to having very severe symptoms. It increases the risk of liver cancer, and it causes inflammation of the liver. So the symptoms that you're going to see when the liver is involved have like GI type symptoms and also color. So if you can just remember GI and color related to the liver, any symptoms that have to do with GI, any STI symptoms that are GI related are pretty much going to be hepatitis B. So it causes lack of appetite, nausea and vomiting, fatigue, headache, malaise, jaundice. So this is where we're talking about the variations in color are jaundice, darker urine, and lighter stools. So normally the bilirubin is excreted in the stool. So if the liver is damaged and we're not getting it excreted through the stools, that bilirubin is going to come out elsewhere. So that's what causes the darker urine. It's being excreted in the urine, and also jaundice, the discoloration of the skin. And then it also causes elevated liver enzymes. And it can also cause chronic liver disease such as cirrhosis, hepatic failure, and even coma and death. So this is another one we can prevent with vaccination. So it's recommended that people be vaccinated against hepatitis B with an effective, let's see, what's the name of this vaccination? Heplisav. And it requires 2 to 3 doses, and it's especially important for healthcare workers because of our exposure to blood and body fluids. And it's also a reason why we use standard precautions with everyone. And if if someone is exposed to hepatitis B, the vaccination can help to treat it. So if it's given within 24 hours of exposure. Sorry, not the vaccination, the HBIG, hepatitis B immunoglobulin. Oh, wait, I didn't look at this chart. So this graph shows at this point of this line is when we started routinely vaccinating everyone against hepatitis B. And it took this was as like infancy or early childhood. So it took a few years to start seeing an effect, but now we can see that it has been greatly protective in the transmission and the incidence of hepatitis B. Okay, so obstetrical implications are all pregnant women should be tested for the hepatitis B surface antigen. And it is a torch infection, and that's why we want to screen to know if they have the hepatitis B, so that we can treat it with the HBIG. The neonate is also exposed to the mother's blood and body fluids during delivery. And we talked about it as a torch infection in our OB unit, antepartum unit. In the infant, it can increase the risk of cancer and liver problems. So it can be quite serious. Both infants bathe infants born to hepatitis B surface antigen positive women thoroughly soon after birth. Infants whose mothers are HBV positive will receive the HBIG, hepatitis B immunoglobulin, and then be vaccinated within 12 hours of birth. After the vaccination, it's safe for mothers to breastfeed, and the CDC recommends that HPV vaccine be given to all newborns before leaving the hospital. So babies who are born to women who are hepatitis B positive, they just need to get that hepatitis vaccination a little earlier, within the 12 hours. It does require parental consent, so we just want to inform parents why it's important. Okay, let's do a little case study. So get ready to type your responses into the chat box. So here's the background. This is NL, her initials, and she's a 17-year-old student, high school student. She comes to the clinic seeking treatment. She's complaining of pain and burning on urination, as well as painful intercourse. She says that she and her boyfriend infrequently have had sex. And she's also seeking birth control, and she's complaining of a yellow vaginal discharge. And upon examination, it's noted that she has abdominal tenderness. All right. So what do we want to screen her for? That's a good one, Stephanie. Anything else? Yeah, that's a good one too. All right, what? Chlamydia, right. Remember, chlamydia and gonorrhea go together, so you'd want to screen for both of those. Very good. So she is screened for chlamydia and gonorrhea. She denies having sex with any other partner, but she does not know if her partner has had any other sexual contact. She's concerned that she might have developed an STI and wants to die of embarrassment. Okay, so what other information should we ask her about? What's a follow-up question we should ask? Yeah, gonorrhea and everything else. Yeah, if she has discharge, good. There's another big one. It has to do with one of the comments in the comment box. Yeah, or warts, good. Lesions, yep, those are all good. Right, are you pregnant? So find out what her Excellent. Find out what her last menstrual period was, when it was, and if she's having any symptoms that would indicate that she could be pregnant. Right, abnormal menses, good. Because that is a symptom, one of the symptoms of gonorrhea. Good. Let's see. What other conditions should she be tested for in addition to chlamydia and gonorrhea? You guys have already covered those. So yeah, you made some good suggestions there. Also trichomoniasis, because anyone who's sexually active who's having symptoms, you'd want to evaluate for trichomoniasis. Sexually active, high-risk sexual activity, I should say. List the medication. So what medications would she be treated with? You guys, good. Zithromycin. Yes, doxycycline is also a possibility. Doxycycline is the one that causes that's, I think, is a 7-day regimen. Azithromycin is the single dose regimen. Penicillin, that one is for syphilis. Ceftriaxone for gonorrhea. Yep, good. List some complications if she does not receive treatment. So if she were to go ahead and not get treated, what are some, oh, no, you're good, Kimberly. This is all a good learning experience. So what are some complications besides pregnancy? Right, she can transmit it. Yes, PID, very good. What's a complication? What are 2 complications of PID? Ectopic pregnancy, good. And infertility, excellent. Okay. Let's see. What information will you include when you counsel her regarding sexual activity and forms of birth control? Yeah, abstinence, recommend that. What else? Yeah, condoms. So barrier techniques. That's a good way. Okay, that's good. Let's just do our little there's a few little FYIs that are just good to know, but you won't be required to study this. And this is my reminder to mention HIV, but I already told you that. So this is bonus. Genital parasites, such as the pubic lice, or which are known as crabs, they are not technically considered STIs, although they are often picked up during sexual contact, and treatment is just topical insecticides. There is a newly emerging, actually it's not that new, it's been out several years, but yeah, they are super creepy and gross, the crabs. We see them in labor and delivery from time to time. Some Mycoplasma genitalium is, this is an important STI, but your text doesn't cover it, so I didn't create its own unit, its own section of this, but I think it's good to be aware that there is such thing as Mycoplasma genitalia. And I've got pictures of Tweedledum and Tweedledee over here because it is very similar to, its symptoms are similar to Tweedledum and Tweedledee. Chlamydia. Its symptoms are similar to chlamydia and gonorrhea. It's got the mucopurulent discharge and the cervicitis and the PID. However, it does not co-occur. Like, you know how we see chlamydia and gonorrhea go together? There's a co-occurrence commonly. It does not co-occur commonly with chlamydia and gonorrhea, so that's why I've got a little space out here between them. But it's got similar symptoms. This is our good news. Chancroid is the STI that is no longer that's under control. We do not see it community spread anymore. And outbreaks, right? Futurama. Good news, everyone. And then the Zika virus is also transmitted sexually. So if a person is exposed, they can transmit it sexually. Mostly it goes from male to female sexually transmission. And it's highly teratogenic. It causes severe microcephaly. So this is a normal head circumference microcephaly, severe microcephaly. And this is what we see with Zika. So it's very bad. There's no vaccine for it. And that's the end of STDs. So let's take a break. Let's take a 40-minute. Well, we'll start at 11:40. No, you don't need to know the bonuses. I included them in your handout just so that you wouldn't, honestly, just so that when we got to this slide, this one right here, which is the last, would have been the last slide you would have if it weren't for the bonus slide. I didn't want you thinking, oh, we're to the last slide and be packing up and thinking you're done. So while we're doing the case study and everything. So that's why I included that information on its own slide. Normally I would have just tucked that into the notes section, but no, you don't need to know that. Okay, yes, 12:40. We will start up at 12:40 with reproductive. So see you back in a bit. Bye.